Hello, everyone. This is Andrew Calloway from the National Council of Urban Indian Health. And thank you all for coming today to our webinar about recent trends in third-party billing at urban Indian organizations. My name is Andrew Calloway. I'm the Senior Research Associate here at NCUI. And I believe Sunny Stevenson is on the line as well. I'll let her introduce herself.
Hi everyone, my name is Sunny Stevenson. I'm an enrolled member of the Walker River Paiute tribe in Nevada, the Gaidakata Numu, and I'm the Senior Manager of Federal Relations here at NCUI.
Okay, so to get us started today, if you could actually move forward a couple slides, we wanted to ask a couple questions to get us started. And again, those are our emails under our names in case you need to contact us. So the first question is, what are the strengths of your billing department? So you can either answer that in the chat box or just think about it as we go through the slides today, up to you. And then the second question is, do you feel like there are opportunities for third-party reimbursement that your program is missing? And why might that be? So these questions are kind of central to what we were thinking about as we put this project together. And they're kind of the types of things that we'd like to be more involved in and answer questions on in the future. And so today we're going to talk about a couple things. So the learning objectives today are to define the relevant third-party payers available to urban Indian organizations and gain a basic understanding of their complex reimbursement structures. 2, we're going to learn about NCUI's project between 2019 and 2020, which collected and analyzed data on UIO billing practices. 3rd, we're going to learn about some national UIO funding trends, which include Medicaid reimbursement rates and overall third-party revenue over the last 5 to 10 years compared to IHS appropriations and HHS grants. And then last, we're going to identify some training resources for billing and coding, as well as some NCUI supports that you can take advantage of. I also wanted to point out, we have this function on our website called the TA request form. It's on the first page, as well as on our Coronavirus Resource Center, where you can ask questions to our team. And we also have on staff, I'm excited to introduce you to Zipporah Fuller. She's our Interim Director of Technical Assistance. So this form is something that if anyone from an urban Indian organization has a question about either billing practices or anything connected to things that they could use assistance on, you can always fill this form out and we will get back to you. So we can both try and address these questions here at NCUI, but that have experienced similar problems and might have more experience. And I wanted to point that out because we received a lot of questions that we can't necessarily all address in one presentation today. But we want to pose this as the start of an ongoing conversation around billing and reimbursement, where we can provide more technical assistance on this topic, as well as learn more about how to support you with resources we have. So a little bit more about the project we're presenting today. We can move to the next slide. The purpose of this analysis was to provide an overview of how urban Indian organizations bill third-party resources. So this is part of a partnership project with NORC as well as Centers for Medicare and Medicaid. And we were particularly interested in CMS resources, so Medicare, Medicaid, CHIP, as well as marketplace insurance, as well as other third-party resources. So the goal was to share data insights, including information such as the percents of amounts billed and collected, along with identifying some best practices that facilitate successful third-party reimbursement. We modified this project partway through, and I'll show you when that came up, but to address the impact of the coronavirus public health emergency and provider relief funding legislation. So that'll be a little bit in here as well. And then the last part of this introduction is a roadmap for what we're going to cover today. So on so we're covering the introduction right now, but then we're going to go over a brief review of some third-party payers, the methods we use for putting this report together, as well as the data sources. And then I'm going to go over some findings from our report, which will be published soon. You'll all get a copy in the follow-up email from this webinar. And that will include some general third-party program service revenue, some information about Medicaid reimbursement rates, Medicare Part B, and a little information about misclassification of race in our data sets that we used, as well as some basic information about the impact of the coronavirus and some recommendations out of this report. So with that, I'm going to hand it over to Sunny. She's going to go over some introduction to urban Indian organizations, as well as third-party payers.
Thank you, Andrew. So the next slide here is a map, and you can see the 41 urban Indian organizations that the National Council of Urban Indian Health, or NCUI for short, that we represent across the country, and that includes over 70 individual facilities of those programs. Next slide. So the IHS, or Indian Health Service, IHS, Office of Urban Indian Health Programs, or OUIHP, you'll hear that a lot. It funds 4 types of UIO programs: outreach and referral, limited ambulatory, full ambulatory, and outpatient and residential substance abuse treatment programs. Each program type differs in terms of service delivery model, staffing, and program expectations. Sorry about that, I'm gonna mute my speakers. A full ambulatory program provides direct medical care to the population served for 40 hours or more per week. In addition to medical care, full ambulatory programs often offer a host of other services as well to best serve their communities, including transitional housing, nutrition, oral health services, inpatient or outpatient substance use disorder treatment centers, elder services, and programs for new mothers. Whereas a limited ambulatory program does so for less than 40 hours per week. And those are listed on the next slide here. There we go. And on to the next slide. So outreach and referral programs do not provide direct medical services, but instead they provide referrals to specialists, in addition to wellness, prevention, and community programs. Next slide. Outpatient and residential substance abuse treatment programs offer a range of alcohol and substance use disorder services, including prevention initiatives, outpatient counseling, or residential treatment centers. For the purposes of our report here, residential and outpatient facilities are considered separately, given that they have large differences in services provided and reimbursement methodologies. Next slide. So now we're going to get into the relevant third-party payers. Next slide. So this slide shows you one of the many really great outreach and education materials that you can find on the CMS website. So the Division of Tribal Affairs has a special section on their website where you can order brochures and fact sheets, stickers, posters, CDs, all sorts of different things that you can use to educate your patients. And this one right here, this is actually a poster. It reads, did you know that your third-party money helps support this clinic? Look around and see your third party at work. And so there's actually stickers that you can use to place in different spots in your clinic to show how you're using those third-party dollars that you're getting back. Next slide. So the first third-party payer we're going to go over is Medicaid. So Medicaid provides health coverage to 73 million Americans, including eligible low-income adults, children, pregnant women, elderly adults, and people with disabilities. Medicaid is administered by states according to federal requirements and funded jointly by states and the federal government. States may offer Medicaid benefits on a fee-for-service, or FFS for short, basis, through managed care plans or both. Although the majority of Medicaid enrollees are in managed care plans, the majority of Medicaid spending still occurs under fee-for-service arrangements. So a little bit more about what fee-for-service is. The Social Security Act requires that the fee-for-service provider payments set by states be consistent with efficiency, economy, and quality of care, and sufficient to provide access equivalent to the general population. Under this fee-for-service model, the state pays providers, and then the states may also leverage the fee-for-service model to promote certain actions or efforts among providers, if appropriate. For example, a state within applicable federal payment limits could determine to pay providers that utilize health information exchange at a higher fee-for-service rate than providers who do not. Although they vary greatly by state and by service, on average, Medicaid fee-for-service physician payment rates are 2/3 of the rates that Medicare pays. Under managed care, the state pays a fee to a managed care plan for each person enrolled in the plan, and then in turn, the plan pays providers for all of the Medicaid services a beneficiary may require that are included in the plan's contract with the state. And then lastly on here is the prospective payment systems and as well as alternative payment methodologies for FQHCs. So the FQHC prospective payment system, or PPS, recognizes that FQHCs, or federally qualified health centers, are a unique type of provider. So under the FQHC PPS, health centers receive a single bundled rate for each qualifying patient visit. However, PPS rates have not kept up with inflation. The Social Security Act also gives states and FQHCs the ability to agree to use an alternative payment methodology, or APM, in determining Medicaid payment rates. In April 2016, CMS State Health Official letter, or often called a show letter, there's a lot of alphabet soup here. Show letter provides guidance to states on the requirements for payment methodologies for FQHCs under managed care. Next slide. So CHIP, it stands for the Children's Health Insurance Program. To provide health coverage to eligible children, states can operate CHIP as a program separate from Medicaid, as an expansion of the Medicaid program, or as a combination of both program types. Like Medicaid, CHIP is administered by states according to federal requirements and funded jointly by states and the federal government through a formula based on the Medicaid Federal Medical Assistance Percentage, or FMAP. I think a lot of us know about the FMAP issues. As an incentive for states to expand their coverage programs for children, Congress created an enhanced federal matching rate for CHIP that is generally about 15 percentage points higher than the Medicaid rate, averaging 71% nationally. For example, if a state has a 50% match rate for Medicaid, they may have a 65% match rate for CHIP. States may not impose cost sharing on American Indian and Alaska Native children through this program. So with managed care, CHIP managed care providers, under CHIP managed care, that provides for the delivery of CHIP health benefits to eligible children through contracted arrangements between state CHIP agencies and managed care plans that accept a set per member per month, or PMPM, or that's also known as capitation payment for these services. And next slide, please. So then we get to Medicare. And Medicare is a health insurance program for people aged 65 or older, or under 65 with certain disabilities, and those of all ages with end-stage renal disease. The different parts of Medicare help cover specific services. Most people pay a monthly premium for Parts B and D. So Medicare Part B is, or medical insurance. Part B helps cover doctor services, outpatient care, and supplies when they're medically necessary. Medicare Part D is prescription drug coverage that is available to everyone with Medicare. They need only to join a plan approved by Medicare that offers Medicare drug coverage. So next on this list is Medicare Advantage plans. So Medicare Advantage plans are a type of Medicare health plan offered by a private company that contracts with Medicare to provide Part A and Part B benefits. Most Medicare Advantage plans also offer prescription drug coverage, and plan rules and costs vary. People can join a separate Medicare prescription drug plan with certain types of plans that either cannot offer drug coverage, like the Medicare Medical Savings Account plans, or they choose not to offer such service, which happens with some private fee-for-service plans. And lastly on this list is the Medicare Prospective Payment System, or PPS. We saw that earlier for FQHCs. So the ACA established a payment system for the cost of FQHC services under Medicare, that happens a lot, Medicare Part B based on prospectively set rates. The PPS for FQHC final rule published by CMS in 2014 implemented a methodology and payment rates for FQHCs under the PPS beginning on October 1st, 2014. Under the Medicare PPS, Medicare pays FQHCs a single encounter rate per beneficiary per day for all services provided, with some exceptions. For example, the rate is adjusted based on geographic factors. Medicare pays FQHCs based on the lesser of their actual charges or the PPS rate. Next slide. And that brings us to the marketplace. So as defined in the Affordable Care Act, a qualified health plan, or QHP, is an insurance plan that provides essential health benefits with the acronym of EHBs, and that follows established limits on cost sharing and meets other requirements. The certification process and regulating body will differ depending on whether the marketplace is the federally facilitated exchange, a state-based exchange, or a state-based exchange on the federal platform. One of the requirements to achieve QHP certification is to have a sufficient number and geographic distribution of essential community providers, or ECPs, where available. So ECPs are defined as providers who serve predominantly low-income, underserved individuals. CMS has established two ECP standards, the general ECP standard and the alternate ECP standard. One of the requirements for issuers to satisfy the general ECP standard is to offer contracts in good faith to all available Indian healthcare providers in the plan service area for the respective QHP certification plan year. This can be easily facilitated by use of the model QHP addendum for Indian healthcare providers. ECPs are eligible to purchase drugs at a discounted rate through the 340B drug pricing program, and may include state-specific categories and benefits beyond the core set of federal provisions. EHHS, or the Department of Health and Human Services, maintains a rolling list of ECPs broken into federal categories. Providers can petition to be added to this list year-round. And now I'm going to hand it over to Andrew to talk about methods.
Yes. So actually really quickly, Sunny, I was just curious, could you cover really briefly a HRSA 330 health center, and when we talk about FQHC versus a CMS FQHC? I can cover it in my section as well. I just want to, it might fit well in this first half.
Okay, so the definition of QHC is pretty complicated, and to simplify it the most, I would say, okay, so there's the Health Resources and Services Administration, and they have a health center program, which is also often called the 330 program, and you can enroll in that program and be a 330 grantee, or you can qualify for that program but not be enrolled in it, and you are technically then a lookalike, and that's the HRSA program. So, but then on the reimbursement side, is if you're an FQHC, you're eligible for different methodologies based on that. One of the most recent things that you might see in your state is a push for an alternative payment methodology based on a new designation called the tribal FQHC. So what an FQHC is, what a health center is sort of complicated to understand, but I hope that gave you a small overview. And Andrew, you can keep going if you like.
Yeah, thank you. And that wasn't to put you on the spot, Sunny, but I guess my question, why I asked that is, when we started this project, it quickly became apparent that when you're trying to put together a national picture to answer a lot of the questions that we get here at NCUI, such as, recently we get questions around what has been the third-party reimbursement loss due to coronavirus. Like, we get those questions, and there's all these different payment methodologies. There's a lot of different, this alternative payment structure that are available in different locations. So the question always becomes for me, what, yes, but where are we talking about, or something like that. So we have to kind of get into these details more when we're trying to provide information to a partner when we get questions like this. So this research plan was started in the fall of 2019 to try and get into how those details relate to the volume of claims and reimbursement in all these different federal programs. We started the project in the fall of 2019, just identifying relevant literature and helping and finding some outside and secondary data around this topic. And the goal was to put that all together, and then in the spring, launch a survey and a qualitative supplement around the time of our spring conference in March. Clearly, we canceled the conference because of the coronavirus in March, and that also made, kind of asking our member UIOs more about their billing practices sort of a secondary priority, because the goal at that time was, really quick emergency support, and asking, about the last year, 2-3 years of billing data would have put a lot of sort of administrative burden that we didn't want to add to that scenario. So instead, we ended up, accidentally hit end instead of next from current slide. All right, there we go. So we ended up relying a lot more on these secondary and outside data sources that we collected in that first half. So I'm briefly going to go over these just so that you're aware of where the figures I'll have in the second half of this presentation are coming from. So the first here, when we're talking about HHS, Health and Human Services grants, these are tracked for the last 20 years on the Tracking Accountability in Government Grants System, TAGS, on their website. So an easy way to get to this is to search for a grant that you know a facility is receiving, and then you can find the identifier information for that program and look at other grants they're receiving from HHS. So I did this, and 90% of the 41 urban Indian organizations are in this data set. There's a couple that are missing just due to some administrative issues. However, they are relatively small programs when we're talking about finances compared to the other 90% of UIOs. So that means there's a pretty small margin of error when we're talking about the grant funding information that I report later. And that margin of error is reported in full detail in the full report. So moving on, I also collected the program service revenue from the IRS tax form, which is public information 990. So these are the phrase program service revenue is what is reported on the yearly IRS tax form. It's a decent proxy for the total third-party reimbursement number for each program per year, per tax year. It's generally available prior to 2018, and I collected the last 10 years, so that's fiscal years 2008 to 2018. The strength of that approach is that it's generally consistently available across all urban Indian organizations, so it can be a rich source of data in that respect. It does have its limitations, which is that it doesn't necessarily have granularity between the programs. We can't necessarily know if a dollar came from Medicare versus Medicaid. And it does have some limitations in that there might be other sources of income reported within there. We think they're small compared to third-party reimbursement, but for instance, if a facility has a very, very small income, like a couple $1,000s from speakers' fees for a year, or delivering trainings to a community partner, those might be reported in that as well. Again, though, based on some sensitivity analysis we did, we assume that at maximum, that's like 10% across the national picture, but it's likely much smaller. Somewhere around a couple percent of this might not be third-party revenue from payers. And then the last limitation is that it is pretty time intensive. I wouldn't necessarily suggest doing this again long-term, but just from the staffing perspective, but it was helpful to get an overall picture. So I'm going to move on, and we do also have some specific information in this presentation today about Medicaid and Marketplace. So the Medicaid information, a lot of this is public information at the state level, in the sense that the state reports this on their website. So that is the case with the vast majority of the information today. I also cross-checked this with internal surveys that NCUI had produced over the last couple years, where we asked for similar information just to make sure that what was reported was up to date. So those are some figures there in that we have this number for 80% of urban Indian organizations, and then 78%, we have a number from this year. To 22% of them, we have a number from 2018. So there's about 2% there, which is like 1 or 2 programs that haven't been updated in a couple years. But generally looking at the other ones, we can also tell it doesn't change that drastically year to year. I think that's a pretty good picture going on right now. And then I also have, Sunny had mentioned the essential community providers, where you can petition at any time to be put on a list of essential community providers, which qualified health plans look at when building their plans out. So that list also is public information and kept up to date. And I look at that as as a metric of every urban Indian organization is qualified to petition to become an urban or to become a essential community provider, but not everyone is necessarily on that list. So that it may not be a perfect metric of is everybody who's on that list include billing marketplace plans heavily, but it definitely shows an interest and willingness to be on those qualified health plans. And it also shows some details about the programs, which we'll see in a second. Lastly, actually I think there's two more sources of information. One is the Chronic Conditions Warehouse. So this is a list of Medicare Part, oops, sorry, let's go back 1 second. Oops.
This is part of the fun of a virtual webinar.
Yes, thank you. So the Chronic Conditions Warehouse is a claims database of Medicare Part B claims only, is what I referred to. We pulled it from the last 5 years that were available, so calendar years 2013 to 18. Then we included claims from both the carrier file and the institutional file, so that accounts for urban Indian organizations that were filing claims as providers within a provider group, which would be the carrier claims, as well as the institutional claims directly. They were grouped by National Provider Index, NPI, not the Medicaid index number. That was due to it being a more publicly available source of information. It comes from the NPI registry is what it's called. And so we grouped those by the physician group or facility. And just a note, when I grouped things into racial categories, which we will see, we did not use the Research Triangle Institute race code. There's two. One is on the beneficiary file, and one is the RTI code, which checks the race of that claim against the Social Security Index. We chose not to do that because there wasn't strong evidence that it improves classification for American Indian Alaska Natives, and it definitely changes people into the Hispanic category based on last name. So just to avoid any potential problems of unclassifying people, we chose not to go with that. So when we talk about race, I group things into American Indian, Alaska Native, other or unknown, and then a known race that was non-AIAN. All right, and our last sources, so these were mainly as a check on the other ones to make sure that what I was pulling from other sources were in line with other things we have on file. So that includes two policy surveys that went out in the winter of 2017 and 18. These were collected at the same time period as the data that I pulled from other sources, so I thought it was a good check because some of our programs may have changed their FQHC status since, so I just wanted to double check things against that. You'll also see a little bit from our COVID-19 needs survey, which went out in late March. And then we also had a couple sources from websites directly from programs, as well as HRSA's publicly available UDS data system. That's not in this presentation, but it is in our report, so I pointed out. All right, on to the findings. So, oh goodness. There we go. Okay, so when Sunny mentioned we have these UIO types and we have limited ambulatory, full ambulatory, this is just a graphical representation of how people fit into those different categories. So you see about half are full ambulatory, slightly over, and then roughly equal proportions between the other 4 types of programs. And then This graph on the right is how we have records of people billing as a HRSA health center, an FQHC, a lookalike, no status on record, which is about a third of folks, or uncertain. Uncertain is because when I was checking some of the data sources against each other, they may have disagreed on that status, likely because they were collected at different time periods. So just to account for those programs who may have been changing during this time period, I wanted to account for them separately, so not to throw off the other categories. So we'll see a little bit of that in the how that panned out going forward. And then getting back to this question of Marketplace and our urban Indian organizations listed as essential community providers, we see that just over half are, that's 25 programs, but 16 aren't. And the interesting thing here is that under the alternate designation that Sunny mentioned, every UIO is eligible to petition to become this type of provider, but it may indicate that the benefit isn't fully there, and it would, just because you end up on this list doesn't mean you necessarily end up on a qualified health plan. So that's something we're going to try and keep an eye on going forward. But this was useful to go through the process of doing, because now we have a better sense of who is and is not listed as the status. So the first data point I wanted to really get into was this overall program service revenue. So this is the top line, all sources of those third-party reimbursements. How is this, what is the national picture at urban Indian organizations? So this is not a graph about urban funding. This is a graph about the ITU system as a whole. And this is from a Kaiser Family Foundation report. The overall report is very helpful, but it is about IHS facilities, tribal facilities, and urban facilities as a whole, breaking down the sources of funding to the ITU system. And it's great because you can see what percent comes from what source. Here we have the clinical services, facilities and administration, the percent that come from Medicaid, and the urban Indian health line item, which is 1% of the overall budget. But the problem with this report is that often it's not as helpful for our purposes because we have a lot of question marks. We know this missing space here is facilities funds that we're not, our programs are not eligible to apply for. These clinical services are purchased in referred care, as well as other funds that are not for urban Indian health programs. So this 1%, we know it's on the board. And then we have all these questions about how much funding is from third-party revenue, how much is it broken down by different type of payer. So after collecting all the information I described in the methods, I was able to put this graph together. So here we have the total third-party reimbursement on this blue line. After this dotted line, it's projected because we only have until 2018. This is the urban Indian health line item in teal, which is pretty static over the last 10 years. And here we have grants from Health and Human Services that do not come from HHS. So we see that 10 years ago in the data period, or in the period I was collecting for, we have all three sources of funding pretty close to each other. So it's about 1.5 times jump between non-IHS Health and Human Services grants, the IHS Urban Indian Health line item that's appropriated by Congress, and then the program service revenue income. And then after changes, some of which Sunny described after the Affordable Care Act goes into effect, we see an accelerated change between the proportion between those three different sources of funding. So The last year we have on record, which was 2018, for third-party reimbursement, approximately 158 million would have been coming from third-party reimbursement. The urban Indian health line item is about 51 million. So that's about triple, whereas before it was not even 1.5 times the amount. Interestingly, grants from sources other than IHS are almost reaching the same amount as the urban Indian health line item by 2019. And then I also want to draw attention to the projected amounts for 2020. We know this number is going to be different because of the impact of the coronavirus, but had things followed the same trend as the past 5 years, UIOs as a whole would have collected about 213 million in third-party reimbursement. So that fills in some of the numbers around the proportion from the line item versus the proportion from other sources. I also wanted to focus in on the proportion of grants coming out of EHHS to urban Indian organizations. So this is the last 5 available years between 2013 and 2019. And for this one, I included the grants coming from IHS. But I also wanted to highlight there's a large proportion, so a third of the money coming out of HHS in the form of grants is coming from HRSA, and about 20% from SAMHSA, as well as some significant but smaller proportions from the CDC and CMS. So this helps us understand a little bit better how changes to grant structures within these different agencies might affect urban Indian organizations, but it also lets us know maybe some room for growth and inclusion of urban Indian organizations within different agencies. So going back to, we have all that information about grants, we have all that information now about program service revenue. How can we start filling in some of those gaps when we get questions about third-party reimbursement? So we still know here at the urban Indian health line item every year, but I can start filling in some of these question marks. So we know that between the line item and third-party reimbursement, there was $125 million approximately of funding being collected by urban Indian organizations across the country, and another $25 million in grants that year in 2014. We also know that even though the line item is 1% of the IHS budget, we also see that urban Indian organizations pulled in 5% of the overall revenue from third-party, or the overall collections from third-party insurers that were going to the ITU system. So when you compare the Kaiser report to our report, we see that the proportion of collections is actually higher than their representation in the IHS funding. And then we still have some of these questions around what percent of that third-party collection is from Medicare, what percent is from private insurance, what percent is from Medicaid. The program service revenue also shows us over time which programs are reporting $0 of this, this service revenue. So again, that includes both reimbursement for services as well as, for instance, small administrative fees. But we see that generally over time, collecting this reimbursement is more and more attractive to programs. But we also see programs going back and forth between reporting $0, collecting a small revenue, reporting $0, and sometimes it's different programs. So I find this to be kind of a good way to track using data how some programs might have a long journey setting up revenue collections and then sustaining that reimbursement over time. And I'm just going to present a couple basic findings from this report before moving on to the conclusion. So I might blow through some of these graphs. I just wanted to include them in the slides for today so that folks can refer to them. So this approach also lets us come up with a ability to see how much of the national picture on total revenue collected by, how much of the national picture on these third-party payers, how much of that is going to what type of program, as well as see on average how much each program within that category collects as a whole. So here we have the overall revenue by program type in fiscal year 2018, and the colors on the pie chart match to the colors on the bar chart here on the right. On the left, we see that even though they're only about half of UIOs, so there's just over 20 full ambulatory programs, they actually make up about 90% of the program services reimbursement going to UIOs nationally, which means that yes, they're providing a lot more and different services, but there's also room for growth in some of these program types. We also see that on average, they're pulling in around a little over $6,000 per program. Again, that's a very rough average because some programs collect a much larger amount and some a little bit less. But on average, full ambulatory programs collect the most facilities, followed up by mental health and substance abuse programs and residential treatment programs. The main thing I wanted to point out here, though, is the very comparatively small per facility reimbursement to limited ambulatory programs. And that's something we want to look into more on how to support those programs to collect more. I'm going to go on to the next slide. This is a similar graph when we talk about, oh, it just keeps moving. This is a similar graph, goodness. When we talk about FQHC status. So again, not too much to point out here. It goes into more depth in the report. I will point out that the uncertain is almost the same as the HRSA health centers, which to me says that some of these programs were likely in the middle of transitioning between the type of FQHC status they had in the time period I was collecting. So they're actually likely FQHCs, and it's just good that they were accounted for separately. But then I want to show the, for those programs who don't report any FQHC status, again, it's much, much smaller, and they're a much smaller proportion of the overall revenue. And then lastly, when we talk about the essential community provider status. So again, this was only 25 of our 41, so just over half have this status, but the difference in the amount of reimbursement available for those programs is very, very different. So those without that status, on average, collected around $4 million less per year, or in 2018, I should say. And pointing out here the different types of essential community providers. So Urban Indian Health Program, the second to the last, this is the designation that's available for every urban Indian organization to petition for. But I find it interesting that even though 25 of the urban Indian organizations are listed as essential community providers, 22 are listed as urban Indian health programs, meaning that even for those who are currently listed, there's a potential for inclusion on more of these categories. It's likely that the more categories you are listed as, the higher potential for reimbursement from these qualified health plans. So that's just something to point out here, is there's a lot of diversity in the types of services that are provided, including family planning, dental providers, as well as being listed as an FQHC. Briefly, gonna describe some of the information we collected about Medicaid reimbursement rates. This is a box plot. This line here in the middle is the average reimbursement rate at the facilities we have on record. So the average reimbursement rate is around $250 per encounter. And the all-inclusive rate available to IHS and tribal facilities is up here at $479 in the last year. So this shows this big blue chunk in the middle is 50% of our programs actually fall between $170 per encounter and $300 per encounter. And then there's this wide range between $70, which is the lowest we have on record, to, again, the all-inclusive rate. And this just shows when we're talking about a national picture, this large amount of potential reimbursement that's missing from the entire national program. So we see all these missing pieces of the pie, where some programs have, $30 less per encounter, some have $160 less, up to, $300 less. Whereas parity, every single program would have the same rate, and it would be that 100% FMAP. Or sorry, that would be the all-inclusive rate. Merging concepts here. I want to have time to conclusions. I just wanted to include these in the slides for today. So I'm actually going to skip most of these, but this is our Medicare claims information. Very briefly, I'm just going to say some top-line findings from each of these slides. We were able to measure the total beneficiaries per year in this data set, and there are some big question marks around using claims data, largely because, or at least when we talk about breaking it out by race category, because even at urban Indian organizations, we are finding this large spread between programs who have a small amount of people with other or unknown race, or very high. So this might be missing or just other race attached to the claims file. So it goes up to 20% at some facilities and as low as 0 at others. This matters largely because we see this growth in the other or unknown category in the number of claims per year. It's very small, but it's there. And then when we talk about claims versus reimbursement, we see a steady growth in claims in the number and the value of claims over the past 5 years. So, and when I say past, I mean 2013 to 2018. And then the total reimbursed, though, the growth is much slower. And that's something that there is a slight difference based on when you break it down by AIN labeled claims versus non-AIN labeled claims and reimbursement. However, this could just be an artifact of misclassification, but it is in the full report. And that's something that when we talk about the different payment methodologies and some of the AIN specific legislation that Sunny described, it's something we just want to keep in mind. So going back to the initial theme, the initial themes that we pulled out of this project, it helps because it really points out how much third-party reimbursement is concentrated in some programs that have multiple revenue streams, but it also points out that there's a lot that maybe we can help support when it comes to more distribution for all urban programs and patients. It also helps because here at NCUE, we have a slightly better capacity now to identify programs, how they might be affected by changes in federal programs, as well as set up some work for future data needs. So we can better estimate the impact of things like work requirements or 100% FMAP. In the interest of time, I'm just going to skip to the conclusions and point out that on this slide, as well as in the full report, something we can pull from this report is there is a estimate for the amount that was lost over the course of 3 months compared to the amount that was projected, which is about $55 to $60 million this year so far because of the coronavirus. And again, I just want to point that out as a potential benefit from this project. So moving forward, we'd like to establish more routine data collection, whether that's from surveys or secondary data sources. I'll be working on this in the future, and my contact information is at the end of this report, as well as on our website and the end of this presentation. And I want to hand this off to Sunny, who's going to be covering the next couple slides with some resources that programs can use to better to improve reimbursement.
Thanks, Andrew. So this slide here, this shows the impact of COVID-19 policy changes with actions taken and suggested actions. And so there have been several legislative packages focused on coronavirus relief. Currently, both the House and Senate have introduced their own versions of the next package, and it's uncertain when they will conference or come to an agreement on the next package's terms. In the interest of time, I'm just going to touch on several examples of administrative actions that have been taken. So while UIOs have been trying to transition more towards remote health service delivery mechanisms like telehealth, these services have not been consistently reimbursed at the same level as in-person care. And as Andrew went over, UIOs are experiencing millions in lost third-party reimbursement as a result. UIOs would benefit from the ability to access relief funds for the purpose of covering past or current COVID-19 healthcare expenses. Earlier on, UIOs and their national Indian organization partners, we've been pushing and urging Congress to create a $1.7 billion relief fund, whereby Indian health programs can submit claims for relief funding based on their healthcare service needs or losses related to COVID-19. So some specific administrative actions taken by CMS have been regarding the Medicare program. On April 15th, CMS announced that the Medicare program would nearly double payment for certain lab tests that use high throughput technologies to rapidly diagnose large numbers of COVID-19 cases. So in effect, the agency increased the reimbursement under Medicare in order to expand testing, particularly in hard-hit components of the healthcare sector, including long-term care and other facilities that see a high proportion of Medicare patients. This also confers a benefit to UIOs, particularly those operating facilities in high COVID-19 incidence areas and with a high proportion of patients enrolled in Medicare. So CMS also took other steps to broaden coverage for telehealth services under the Medicare program and to enable Medicare beneficiaries to receive a wider range of services that would not require traveling to a healthcare facility, thereby reducing the potential exposure of patients and practitioners to others who may have been exposed to the virus. Additionally, during this public health emergency, CMS uses 1135 waiver authority, and that enables Medicare program to cover office, hospital, and other telehealth services from providers, including doctors, nurse practitioners, and other certain kinds of healthcare providers. And that was starting on March 6th. And the eligible services include common office visits, mental health counseling, and preventative screenings. Additionally, CMS informed Medicare Advantage organizations and Part D sponsors via memorandum of many flexibilities that they may utilize during the pandemic. Under Medicaid, given that each state has different Medicaid rules governing telehealth, on April 23rd, CMS released a toolkit for states to accelerate the use of telehealth in Medicaid and CHIP during the COVID-19 pandemic. States also have been using the Appendix K process to broaden or otherwise change their Medicaid programs in response to COVID-19. For example, Arizona's Appendix K expands locations where services can be provided. And I think we can move on. Let's see. Oh, actually, you know what? Let's, I'd like to touch on some of the suggested actions as well. So we would like to see increased Medicare utilization at UIOs, more outreach regarding the dual eligible programs when individuals are eligible for both Medicare and Medicaid, enhancing the visibility of UIOs, the authorization of 100% FMAP, the parity and medical malpractice liability, and that's otherwise known as FTCA or the Federal Tort Claims Act, and an increase in access to facilities funding to remove the limitation in the Indian Healthcare Improvement Act and establish current and future UIO facilities assessments. Next slide, please. So now we're going to go over some select training resources. We're a couple minutes over, but this next slide here, we wanted to show how broad the range of questions that we received from you about what you would like to see addressed in this webinar or in future webinars. So here, there's a range from very specific questions regarding behavioral health crises to very broader just coordination of care or how to comply with intergovernmental agreement compliance there. And a lot of you are very interested in specific billing and coding education, and you would like to see events that award CEUs or continuing education units. So next slide, please. So here is, and I say this wrong every time, and it's Novitas, and I always want to say Novitas. Novitas Solutions, they are the Medicare administrative contractor for the Indian Healthcare System, or MAC is the abbreviation for that. Right here on this slide, we have the website for the portal that has information for Indian healthcare providers. So Novitas has right now, during the month of August, they're conducting a virtual symposium with 4 webinars, 2 each day. CEUs are available. These are free, and they're going to have a lot of information about coding and billing and patient screening and eligibility. So in order to participate in these, you do need to register and have an account in the Novitas Learning Center. Next slide, please. And that brings us to the CMS ITU trainings. And these are regional trainings that usually take place in person every year, and they're virtual now. So CEUs are still available. And right there, it has the terms of getting 1 with up to a maximum of 14 for the virtual training series. Right now, registration is open for California, which is taking place right now. and also for Portland, Nashville, and Bemidji IHS areas. And we really encourage you to sign up for these and get the information, get the handouts, get your billing departments involved. They're really great opportunities, and the content does span a lot of different categories. So you can look at their agendas and find out what you're most interested in. Next slide. And that brings us to the conclusion. Thank you so much for attending our webinar. And Andrew, did you have any parting thoughts?
Yeah, I just wanted to thank our partners, NORC and CMS, Office of Minority Health and Tribal Affairs on this project for their review of the report, as well as providing us with their expert insight as well. And then just a final plug for please contact either me if it's a question about the report and data, Sunny if it's a question about all these policy changes going on. We'd love to support you as much as possible, as well as connect you if you have questions to another urban Indian organization. We can always respond to TA requests that come in either through our emails or our website. So, make use of those resources that Sunny provided, but also we're always happy to be a resource. And with that, you'll be receiving a final email if you registered for this with the report, as well as a brief evaluation. Again, it might ask some questions about how can we support you going forward, and what do you want out of these webinars, as well as communities of learning, and the slides. So yeah, that's all I have, and thank you all so much for coming. Thank you, Sunny, for working on this project with me, and the recording will be both on our website at the link that you entered through when you attended today, as well as sent in the follow-up email. So thank you for reminding me on that. And thank you all for attending. I'm gonna close this room and have a great afternoon.
Thank you.